So I want to introduce my colleague from the Department of Ophthalmology, Linda McLoon. And Linda and I have worked together and collaborated on a lot of blepharospasm research over the last 20 years now, probably, since I was a... She's much younger than... but Linda's going to talk about what's new in blepharospasm research. Thank you.
Thank you, Andy. So hopefully I won't bore you, and if something is unclear, really feel free to interrupt me. Okay, so I'm not talking about everything that's new. I'm just going to kind of talk about what we're doing, because obviously that's what I know the best. So is this a pointer? So just to kind of, I'm going to start with the easy and work toward the actual research experiments. So if we think about muscle, and I've got kind of a cartoon here of muscle. The way muscle is organized in a very interesting way. There's an individual muscle fiber, and these are very unusual cells. They're very long, and each single muscle fiber is connected together with a lot of other ones and bound together with connective tissue, and which forms a muscle fascicle. And then the whole muscle is multiple of these fascicles bound together and more connective tissue. But the facial muscles are a little bit different, and I know that you've seen a couple pictures like this, so I have a slightly different atlas. But what you can see, the facial muscles, normally when you think about a biceps, right, you have big, long fibers, and they connect to bone, and they cause movement of a limb, for example. But the facial muscles are different. They actually insert into the skin, right? So so that makes them rather unique relative to most of the other skeletal muscles in the body. And so the next picture is going to be this area blown up. Okay. So right here. And so we're going to focus right on the Bicularis oculi muscle, which is the muscle that closes the eyelid. And I need to kind of define, I think maybe it might be better if I use this arrow. What do you think? Maybe I can't make it move. So because I'm going to use these terms relative to how we look at the muscle in the laboratory. So the eyelid itself is covered with two component muscle parts. So if you were going to have a myectomy, they would have to go in and remove both of these areas of muscle in the eyelid. One of them is called the pretarsal, which is a little kind of hot dog shaped fascicle of muscle right near the eyelid margin, and then this preseptal region, which is on the eyelid, and this functions mainly for gentle closure of the eye. And then surrounding that is a larger portion that actually sits external to the orbital margin bones, called the orbital region. And for the research that we do, we tend not to do that portion of it, but that's the part that's going to be involved in that forceful closure. And I know that Ali talked a little bit about the corrugator and some other muscles that are also involved. But what you can see is that this is a very complicated muscle. It's innervated by a single nerve that comes out right here behind you where your ear is, where that bony mastoid process is, and has a very complex connection across the face. And so the actual nerves on the face are very complicated in terms of their pathway. But every single one of those individual fibers in every single fascicle will get a connection from that axon in the form of a neuromuscular junction. And we saw some beautiful pictures earlier with the release of acetylcholine. And so here's one of those axons, one of those nerve fibers coming down, and it forms these very specialized structures that allow the brain to communicate with the muscle in terms of controlling contraction. And it releases a chemical called acetylcholine to cause the muscle to contract. And what's kind of unusual about the orbicularis oculi and eyelid muscles is that the fibers, instead of being arranged like they are in the biceps, they're very short. And what does that mean? It means that if you go hunting around for where those connections are, those neuromuscular junctions, they're going to be spread out because the fibers are short and every single fiber has to get a neuromuscular junction. And so here's just a cartoon. This is from a paper with John Wirtschafter when he was alive, for those of you who remember him. And so what we did was figure out where these neuromuscular junctions lie. So if you wonder why you get multiple injections in different parts of your eyelid, this is why. It's related to these short fibers and to the fact that if they want to get the botulinum toxin in the places where the neuromuscular junctions are in order to paralyze that communication. They need to make sure the botulinum toxin is where those connections are. The other thing about blink is that it's actually very complex movement, and blink rates and blink speeds, like I was saying, whenever people take pictures of me, my eyes are closed. Because I have dry eyes, I blink a lot, so most of the time my eyes are closed, apparently. And so if you look, these are 5 different individuals, and each individual is given a little color and shape, and you can see that in terms of how active the muscle is and how fast the lid closure is, even within a single individual like this one, look at the difference between speed of closure and force of muscle contraction, right? So the complexity of this is quite difficult to understand how all of these different blink rates are controlled. So what have we been doing in the laboratory? So one of the things that we know happens after you inject botulinum toxin is that you actually can cause the nerves, right, that you paralyze the end of the nerves. And so both the nerves respond to this paralysis with what we call sprouting. They grow new fibers. And the muscles also respond. And so these are from rabbits. And so we can take the muscle out and cut it on a microtome at 10 microns. So it's like little thin wafers. And then we can go look for whatever we're interested in studying using various techniques in the lab. And in this case, we used a fluorescent label to identify the muscle side of those neuromuscular junctions, okay? And so they look like this. So if you remember back to this, what we're looking here is this basically turned green, okay? So you can see in the normal Bicularis oculi muscle from rabbit, there's plenty of neuromuscular junctions, of course, but you can kind of get a sense of the density here, right, in this specimen. And this is 2 weeks after a single injection of botulinum toxin. And so what this means is that because the nerves have been denervated, right, because by the botulinum toxin, paralyzed essentially because of the binding of the botulinum toxin to that SNAP25, the muscle wants to be innervated. So it has a response. And one of the things that it does is it produces the muscle side of the neuromuscular junction a lot, right? A lot of it shows up. Okay, so this is the response to not having a functional nerve on it. You would say this is going to be counterproductive in terms of maintaining the muscle paralysis, right? Because it's going to be putting out various factors that are going to try to attract nerve to grow toward it. And so then we can count this all up, and so this is just looking at the number of those neuromuscular junctions that we dyed green compared to the muscle area. And what you can see is they keep increasing in number as time passes during the time that the botulinum toxin is effective. And so we thought, well, maybe we could work to increase the duration of botulinum toxin if we could prevent the muscle from doing this, right? Because this is the muscle saying, hey, come on, we want some more nerve to grow toward us. And so we had, in a whole another experiment for another reason, used a chemical called corticotropin releasing factor. It's actually a natural hormone. And what we did was we injected the botulinum toxin in conjunction with this corticotropin releasing factor. And so here, you can see that these neuromuscular junctions dyed green. There's fewer of them, right? So this treatment allowed us to significantly, in this rabbit model, reduce this response to being denervated. And so we think this should enhance the effectiveness, the duration of effectiveness of the botulinum toxin injection. And we actually patented this. So we own it. We have a patent, just, see, not the only one. I don't know what it does for us, except, we have one. And so this is a little bit hard to see, but, and you could say, who wants to work in her lab if I make somebody do this? And basically, we can mark every single neuromuscular junction in a whole muscle. And in fact, this corticotropin releasing factor injected with botulinum toxin at the same time dramatically reduced the number of neuromuscular junctions. There's some other natural hormones that have the same kinds of effect. This was an antibody to a neurotrophic factor called insulin growth factor, which also makes nerves grow. And so if we block that receptor, we don't let that insulin growth factor bind to the muscle, we also can prevent all of those new neuromuscular junctions that are going to decrease the effective duration of your botulinum toxin treatment. So then, okay, well, that's great, but is it going to make a difference? So the next one, we just counted it all, and you can see this is really not much different from control when you do enough of them and add them all up together. So we were pretty excited about this, hence the patent. And so we have just started, we kind of put this by the wayside because all of this research is expensive. And the NIH, this is a time for you guys to tell your, congressperson that you have something that maybe they should fund. There's probably very little research funded in this area by the government. But what we were able to see, and this is a different muscle, we were using the muscles that move the eye in the orbit because they're easier to do this kind of experiment. And so what we can do is take the muscle out, tie it to little tiny force transducers and stimulate it and see, is that muscle weaker longer? And so what you can see here is this is control. And we were using a lesser dose of botulinum toxin, obviously, than you might have used on you for your injections. But you can see these black bars, and the details here don't matter so much as the point that you can see here the botulinum toxin injected lids were not that much difference in terms of the strength than the control lids with this particular dose in these rabbits. But when we injected both of these, the botulinum toxin and the corticotropin releasing factor together, we significantly maintained that muscle paralysis. And so we are pretty excited about this, and we have some other studies that are partially done. And then hopefully we'll get back to these, right? So we need a nice medical student to come work on these. So I'm very lucky because I get to work with some really wonderful and brilliant physicians. And one of the things that Dr. Harrison did was collect a lot of muscle that what we call surgical waste. So patients who decided they were sick after 6 years of having botulinum toxin injections and they wanted a myectomy. So we got all of these in the lab. And we were able to take a look, and then plus they have patients who just want a blepharoplasty with, so removal of portion of the eyelid with muscle, because the muscle's attached to the skin. And so we had some normal muscle that we could compare to the muscles from people who have benign essential blepharospasm and had botulinum toxin injections. And we have one specimen where the person just didn't want botulinum toxin injections. And so this person had benign essential blepharospasm and had a myectomy. Okay, so these are all from surgical waste, from surgeries that he would have normally done anyway. And so what we looked at, the two things that we've been thinking about in terms of our ability to manipulate them in the eyelid by injecting the botulinum toxin with a second substance that we think can extend the duration of effectiveness. So if that means you get injections 4 times a year, maybe you'd only need them twice a year. So it saves money and it saves time and it saves just getting lots of injections around your eye. And so we looked at all of just the nerves that are in the tissue from these human surgical waste specimens. And so here's control. And so here it was from the muscles that came from a subject with benign essential blepharospasm and have been treated with botulinum toxin. And what you can see is we measure it a couple of different ways because we can't help ourselves. We love measuring things. And you can see that there's a lot more nerve in this tissue, okay? Because the nerve sprouts when it's been paralyzed by the botulinum toxin, which is counterproductive to maintaining the duration of its effectiveness. But notice also, and because this is an N of 1, it's unclear whether this would be universally true, but even without the botulinum toxin, there's a lot of nerve there that's more than in the control specimens that were age matched. And so this, at least the way my brain works is, you might be able to come up with some other treatment rather than a toxin that might just decrease that amount of nerves that happen to be in your lid, because one could imagine that all of that extra nerve is going to cause extra contraction. So it's an interesting hypothesis, and we'll find out if it's true if we can get more specimens like this, which are very rare, because most people get treated with botulinum toxin, and for good reason, because it works, right? But what we also found was when we looked at those connections between the nerve and muscle, that you can see we saw what we saw in the rabbit. The muscle responds to being denervated by making a lot more of these neuromuscular junctions. But these were not as elevated as what we in the person with just benign essential blepharospasm. So the nerves are there, but they're not connected, right, to the muscles if the neuromuscular junctions are a mismatch. So we think there's something interesting here, and so we hope to follow up in the next couple of years. And I have to just thank my wonderful clinical collaborators and a medical student, Rose Olson, who did all these measurements. So can we extend the duration of botulinum toxin efficacy? And I think our animal studies would suggest, in fact, that we can. And we have a number of candidate molecules, some of which we've tested, such as this corticotropin-releasing factor, which is what our patent is. But there are other potential candidate molecules that may be even more effective or might work on decreasing the overall amount of nerve and sprouting. So there's lots of approaches to use the natural biological response to denervation to try to either treat blepharospasm or extend the efficacy of botulinum toxin, if that makes sense. So while we know a little bit about what causes benign essential blepharospasm, we really don't understand it. Why should somebody get it and another person not? And most of what we've heard already today is that we focus on reducing the symptoms so that you have an improved functional outcome, and that's a perfectly reasonable approach relative to almost anything that you can think of. And if you kind of think back when I know somebody was talking about Dr. Scott, who I guess is still her physician, he came up with botulinum toxin in the 70s. And we really have not had an improvement in terms of thinking about a different way of treating this disorder. And we think that there's a lot of potential strategies and approaches that might be equally efficacious. I will say that. So what have I told you? And hopefully that was clear, because I know it's always hard to talk about rabbit studies and so on. But first of all, that the orbicularis oculi muscle and the other facial muscles are really different than the limb muscles. They're small in size, the fibers are small, and they're short relative to fibers in other muscles, that the innervation of them is very complex, and it's even more complex when you denervate it because it causes all kinds of responses to that denervated muscle. And that we know that there are good surgical and botulinum toxin treatments for benign essential blepharospasm, but we think certainly that we could work towards increasing the duration of its efficacy, or potentially take a different approach and reduce some of the, if in fact we have more nerve, right, that the muscle is just producing something that draws more nerve to it, maybe we can work on that as a pathway, which is a completely different approach than is being used now. So with that, I of course need to thank my fabulous clinical collaborators, and of course Rose Olson, who is the medical student who counted that human material, as well as my fabulous technician, Krista Fitzpatrick, and funding from the Minnesota Lions and the University of Minnesota Foundation. And we did a lot of work early on, particularly with John Wirtschafter, looking at even different approach. And I need to thank the Benign Essential Blepharospasm Research Foundation for funding some of this early work. So thank you. Okay, you sure?
Yeah, I'm good. All right, thanks, Linda. And I want to echo what Linda said about the BBRF. They've funded several of our studies over the years, and it's been really, we couldn't do it without you, so it's awesome. And it's really fun. Now I sit on the medical advisory board of the BBRF to see what kind of studies are being done in this area. But as Linda said, there's not a lot on the treatment side, interestingly. There's a lot about genetics and that sort of thing. But as much as treatment is kind of still, I think, underrepresented. So I'm really excited about our current work.